All right, it looks like we're getting started. Hello, I'm Errington Thompson, and I'm happy to have with me Michael Saag, who, let me just say in short, if I read his whole CV, it'll take me an hour. And that's even if I skip stuff.
Mm.
But let's say he's the Associate Dean of Global Health for the medical school at UAB. He's also been the director, or is currently the director of UAB Center for AIDS Research, professor of medicine in the Division of Infectious Diseases. For my residents, he is the co-editor of the um, Sanford Guide, the antimicrobial therapy, and as well as the Sanford HIV Guide and the Sanford Hepatitis Guide. He has been author or co-author on over 400 peer review articles, and I have had the pleasure of interviewing him before, and so I'd just like to say I'm sorry for shortening your CV, but welcome, welcome. How are you?
Great, thanks. Good to be back with you.
So I'd like to talk just a little bit about COVID because COVID is, it seems like it's always in the news and will not go away. Um, I'd like to start with just a little bit of a history of COVID and what we've been through over the last 2 years. So let's start back in early 2020. And we were starting to get these reports out of China. China by mid-January was having over 300 cases. And we were starting to screen passengers at some of the major ports coming in. Um, what are your thoughts about our early screening procedures? What could we have done? Should we have done more? Should we have done less? How could we have protected the American public a little bit better?
Well, a lot of this is easy to see more clearly in retrospect because we know that this exploded and has killed over 1 million US citizens. So the questions are, what could we have done differently? I think we have to put ourselves back in time, and I would underscore 2 points. One is I like to think of public health as very much like a physician patient relationship where the patient is the population and the physician are the public health officials. So if we put that into that context, the patient comes in, the population comes in at risk for some new disease. And that new disease has got symptoms, that is, exploding cases in China, and we're trying to contain it within a certain area. And there are things that we can do to make that happen. But we also have to remember that, number one, we'd never seen anything like this before, exactly like this. We certainly had seen SARS-CoV-1 or the original SARS virus and MERS back in the early 2000s to 2010 era, but nothing like this. So I think we need to give ourselves a little bit of a break there. But the second part is maybe more important, and that is that over the last decade, certainly accelerating in the last 5 years before this started, public health had become more and more politicized. And I think if I had to point at one lesion that we need to fix, it's to get politics out of public health as much as we can. And I realize that elected officials are involved, and that almost by definition makes it somewhat related to politics. But you take those two things together that we didn't have much information, we'd never seen this before. But I think most importantly, politics had played a huge role. So if I had to wave a wand and fix something, it would be to get politics out of public health, just like we wouldn't want politics to be engaged in our doctor-patient relationships.
One of the things, and I totally agree with you, and I think we'll circle back to that in just a little bit. Um, One of the things that we really, really focused on early on was patient temperatures. We
Mm.
wanted to get the temperature of people getting off of planes, people coming into the hospitals. Was this kind of misguided? What are your thoughts on that?
Well, sure. We learned a lot over the first 4 months, 5 months, that certainly fever was a symptom of COVID, but it wasn't universal by any stretch. And it also changed in terms of the timing of infection. Early on, a lot of people didn't have fever and they might have developed it on day 6 or 7. That's what happened to me personally. So I think we screened for fever because we can do that. And we had had a lot of experience screening people traveling from malaria areas back to other areas, and we routinely had those set up at airports. You could do temperature scans. So I think it was a natural step, but it wasn't sufficient in and of itself. I think screening for any symptoms related to COVID would have been a better approach in retrospect. And that's kind of what we do now. And we encourage people to self select, and if they have symptoms, to not travel or to seek medical attention. Now that we know more about the disease, I think that would be a better approach, but it's what we could do and it's what we did do. So I think it's understandable, but wasn't sufficient.
So when you look at those first early months, January, February, and March, back in 2020, um, this is, of course, a time when we really didn't have any therapy, and we were still learning about how the disease takes hold, how the disease moved forward. Um, One of the things that was talked about, especially amongst the infectious disease people that I talked to at the time, was something called contact tracing. And it
Mhm.
seems like we talked a lot about it, but we really didn't get to that. Would that kind of tie into the politics you were talking about, or what? Why didn't we do more contact tracing?
I think we didn't have the opportunity to act on that when we had the chance. And let's go back to your earlier question of, was screening or watching for people coming into the country from China or elsewhere, would that have been enough? And the answer, I think, is no, because it's impossible to do that. And there were ways around uh, certain screening centers, and the virus is going to get here no matter what. I think the problem that we had with case contact tracing was twofold. Um, but most of it is related to the first issue, and that's we didn't have testing. And if I had to say where there's one place that I think CDC fell down, was that it didn't ramp up testing as fast as we should have or could have. That had fits and starts through February, and so by the time they really got into a testing modality, we were already into March, and I think the cat was out of the bag in terms of where case contact tracing wouldn't work. We can look today at monkeypox and see where case contact tracing does work and is helpful. So if we find a case of monkeypox, the first thing we do is we try to find out who all the exposures were, go and reach those individuals and vaccinate them if we have access to that, and test, of course, and let them know that they're at risk and to limit their contact to others. That's what the case contact tracing could have done for us with COVID. But there was another problem back with COVID, which is a second point, and that is we really weren't 100% clear on how the virus was transmitted. If we think back, based on SARS-1 and especially MERS, those viruses were believed to be transmitted a lot by contact with surfaces. And if you look at, for example, SARS, the original one, most of the cases were among healthcare workers. And so it was felt like touching patients and that type of thing was responsible. So we spent a lot of time educating the public in February about avoiding touching surfaces. You remember, we're wiping down things on
Everything.
airplanes, washing our hands frequently, which is never a bad idea. But we were focused on the wrong thing, just in retrospect. And even Tony Fauci got caught in that crossfire because he very famously said, we don't have to worry about masks right now. I think his comment was uh, based on a couple of things. One, we didn't fully appreciate the respiratory transmission nature of SARS-CoV-2. And the second thing is, and I've talked to him privately about this, that we didn't have enough N95 masks for the healthcare providers. And he didn't want to create a run on those masks unnecessarily and leave the healthcare workers theoretically at more risk because they're on the front lines, along with first responders. So I think in retrospect, he wished he hadn't said that, but on the other hand, we were learning as we go, and that's how it played out.
So, kind of on that same line, and I think this is probably something that you're probably uniquely qualified to talk about. So, we've got this pandemic going on. We're early 2020. How do you study the best way to take care of patients in the middle of a pandemic? It seems like you're trying to catch a train that's moving, and the train's moving faster the
Mhm.
closer you get to try to catch it. So I know there was lots of discussion, there's lots of ethical things to consider, but it seems like it took us a while to figure out how to do that.
It did take us a while, but I would flip that around and say I think it's remarkable how much we learned in a short period of time. And I'll come back to that with a comparison, for example, to HIV and AIDS in a second. But the point is, what to answer your question, you study. Every patient is in essence on study. We want to look at their symptoms. We want to look at what seemed to help, what didn't help. You study intensively every single case, and you hopefully organize it in a way that you start gathering information in real time. And I think actually we did a pretty good job of that, especially out of the New York area in April of 2020. In my own particular case, I got sick mid-March 2020. Ironically, I was driving back from New York with my son on a 20-hour road trip, and we kept wiping the car down. Meanwhile, he's infected. We didn't know it, and he's breathing in this small space with the windows up. I mean, that's a pretty good incubator for picking up the virus. But when I got home and I realized I was infected, the first thing I did was go right down to the medical center. And in addition to being tested, I donated probably 12 to 14 tubes of blood so that the researchers could look at what my immune response was. Later, I even donated through plasmapheresis 500 cc's of plasma and God knows how many billions of cells that they could start looking at my immune response over time. So I think it's that kind of intensive effort on the part of basic science researchers, but also clinical investigators with the epidemiologists to track this. Coming back to the point about how fast it happened, it's easy to be a critic and say it was slow, but actually it was quite fast. If we look at AIDS, for example, the first cases were reported in June 1981. We didn't even discover the virus until March of 83. That's 2 years. We didn't have a test approved until May of 1985. 4 years. Years, not months, not weeks, years.
Years. Yeah.
And so you look at the pace, we didn't have therapy until 1987, 6 years. And we didn't really get really good therapy until 1996, which was 15 years. Now let's look at COVID. The first couple of months, as you pointed out, sure, it was hectic, it was chaotic. And even though we look back and say hydroxychloroquine never worked the way we had hoped it would, we figured that out by, let's say, June of 1980. Meanwhile, a drug that was developed in 2015 to 2017, remdesivir, was looked at originally for Ebola and then for some other viral diseases, respiratory viral diseases, that was immediately put into clinical trials. And by May of 20, it was approved. We also learned that steroid use, when timed appropriately, that's critical, given after the seventh day of illness, really reduced mortality on inpatients. So
And it,
that
and
was
it wasn't an expensive therapy like
no,
remdesivir.
no. And that became available in pretty widespread use by, let's say, June, July. So we started saving lives in medical interventions roughly around May of 2020 and got better at this through June, July of 2020. I will add, I think it's important for the clinicians listening that I very carefully said to give steroids later. If we give steroids early in the first 2-3 days of symptoms, we hurt the patient because there's two phases. There's the innate immune response in the first 6 days that knocks the virus down. And then there's adaptive immune response that really, it being out of control, causes the symptoms of later disease and actually is what I think kills people at the end of the day. That's what steroids are good for. But if you give it in the first 2 to 3 days, you blunt the innate immune response and the virus doesn't get under good control. And so you prolong the illness for people when you give steroids early. And I've seen a lot of urgent care centers make the diagnosis on day 2 and give them a slug of steroids IM. And those people have
Get
much
sick.
more long duration of illness. So coming back to this, we not only got therapies in the first 4 to 5 months, we also started working on a vaccine. We don't have an AIDS vaccine, and it's been 41 years, right?
Right.
We had a candidate vaccine 7 days after the sequence of the SARS-CoV-2 was released in January 2020. We had candidate vaccines. They went into animals in February, started going into clinical trials in March, April. By the summer, we were transitioning to phase 3. And by November, late November, we had data that showed that they were 90 to 95% effective. That is a miracle in our lifetime. But what's better, and to give credit to the previous administration, they allocated funds even as early as May, June of 2020, in case the vaccine worked, to scale up production so that when the vaccine was proven to work, we had production in such levels that we could in a widespread way, distribute the vaccine to millions of people in the United States. Ordinarily, what would have happened is a vaccine would have been shown to be effective, and we would have had to wait at least a year for the scale up to happen so that millions of people could get it. So there's a boatload of things we did well that I think we shouldn't overlook as we go through this post-mortem of the first year or so of the epidemic.
Well, and I'd like to add, just talking about the steroids, in the summer of that year, there was, I don't know, several randomized prospective trials that came out that looked at, one, different steroids, and two, different durations of steroids, when you start them, when you don't. And I think some of the major journals are to be commended because they basically had these roundtable discussions, kind of like we're having now, with experts, and would give us some information as opposed to us trying to pile through every single journal that was pouring out information at that time, which again was is unprecedented as far as I know.
Right. I think the other criticism that spilled into the political arena, especially in April, was the whole notion of lockdown, which has become an evil term. But if we pull back and look at the times, as we've said, this epidemic started to explode in February, March into April, especially in Manhattan. Hospitals were overwhelmed. They're out of NYU Langone, there were out of 600 and some odd beds, almost 100% of them were COVID patients. So you have not only the public health to be concerned about on an individual basis, protecting them, we also had to protect the health system. And that's something that we haven't been asked to do very often. And I think the notion of conservative approach, having people stay at home more, wearing masks, coming into ourselves until we got it figured out, I think we saved an enormous number of lives, not only from people with COVID, but other people who needed the hospital for whatever emergency, heart attacks, car accidents, whatever, that there was at least some room at the inn when they needed to be in the hospital. And while it was a struggle, and there certainly were people who got caught in that vortex, what we did in April as far as lockdown was the right move at that time. And again, I think public health officials should be commended for that.
Well, and I would go ahead and emphasize, not only did we see that in New York, but I think Boston and New Orleans was also getting really, really hit at that time where, as you said, the hospitals were completely full, not just of patients, but mostly full of COVID patients. Which brings me to another point that it looks like the COVID has shined a light on or illuminated, however you would like to phrase it. But we have a hospital supply chain problem, it seems like. and our supply chains were stretched to the limit. Um, if we could make you our healthcare czar, how do we fix that?
Well, we had solutions that we didn't employ as well as we could have in terms of the national emergency declarations and going into stockpiles that were put apart, that were put away for emergencies like this. I think we could have done better there. We could have employed, I think, the military a little bit earlier to help, although we did that, and I'll give a check on that one. But I think what we need to do is rebuild the stockpile and have it available for some other ill-defined future emergency. We have national defense policies that were more or less shelved and disregarded during a 5-year period before COVID. And I think we should re-implement those. I think that's already happening. And like what's going on right now, I think over time, the Center for Disease Control and Prevention had drifted into more of a political realm, just by the nature of the importance of what they do and the interaction between public health and politics. Releasing information, having triple clearances. I know that during the time, any public appearance by officials within the government had to be cleared through the White House before they could go on television. That took time. It interfered. It stamped on the messaging. I think we should let the people we trust to do public health do their job and let them have ownership of it. In other words, it won't necessarily be directly the president's fault if the public health officials make a wrong turn or an error. Of course, the president's ultimately held accountable, but don't micromanage the public health response of the experts who have studied this their whole life, who have remarkable credentials, and let them do their job. Just like, again, a physician would taking care of a patient, we want to make sure that they have the leeway to do what they need to do without undue restrictions because of politics. So I think those are the things I would fix. And right now, I know Dr. Walensky is engaging in a large strategic study of how the CDC operates right now. And hopefully out of that will come some changes that will improve the CDC in the future, their performance and their ability to respond in a nimble way as these things emerge.
So you stole one of my questions, but that's okay. That's all right. So one of the things that we also found out when we talk about public health, we don't really have a public health authority, or maybe I'm wrong. We don't really have a public health authority that's able to tell every state, every municipality, this is what I want you to do from a public health standpoint. Instead, it seems like we have 50 states, and each one of those states has their own public health, own public policy they can take or reject guidelines from the CDC. And that doesn't seem to be the best thing from a public health standpoint. Can we fix this?
Yeah, sure, we can fix it. And the usual way we fix it is with funding. So the areas where there's direct funding from CDC to a state, that funding is often dependent on the state responding to CDC directives. And if the state goes off on their own in a rogue kind of way, CDC just simply pulls back the money. So they can get states to line up pretty well. So I think that in retrospect, the COVID money should have been sent out to the states via the CDC, assuming it was operational and maybe functioning a little better. But that usually gets the states in line. There is a tension, to be fair, between a federalized approach that uses more of a one-size-fits-all kind of design. It takes out the state's ability sometimes to respond locally. So I think there is a tension there that needs to find a balance. And I think we've done that over the years with other diseases, hepatitis C, for example, or even HIV for that matter. other STIs. But I think that as part of that national emergency response plan that I hope is being reconstituted, I think it should start with a federal approach. And then as we learn more, getting input from all the states, again, every state's been different when it comes to COVID, but not letting policy drift too much state to state, because I think harm is done for the sake of politics.
All right, so let's fast forward, and we're now towards the end of the summer in 2022. We clearly have two vaccines which really seem to work extremely well, specifically at preventing severe disease against COVID-19, the Pfizer vaccine and the Moderna vaccine. Both the vaccines seem to have been proven to be extremely fair. I mean, excuse me, extremely safe. That is that a fair statement to start with?
Yeah, it's a
Okay.
very. Mhm.
And then recent data seems to suggest that neither vaccine is all that good at preventing infection to the Omicron variant. Is that correct?
That's correct.
And so we had the FDA recently make the decision that they would like a vaccine from both of these guys, from both Moderna and Pfizer, that attacks both the traditional COVID-19 plus this Omicron variant, and they would like that to be ready kind of in the October, November range. What are
Mhm.
your thoughts on that, and what are the pluses and minuses of this particular strategy?
Overall, I like the approach. Let's back up. When the original strain vaccine was released in December 2020, and it started getting widespread use, if you remember, the numbers came down substantially in terms of new cases. And it was believed, and it's probably true, that the vaccine prevented not just severe illness, but at that time was preventing infection, or at least symptomatic infection. And so it was successful. Then we all remember July 2021 in Provincetown, Cape Cod, Massachusetts. 75% of a population who were gathering together who were vaccinated came down with COVID from that exposure. And that was because the Delta variant had emerged. So what it said was that the original vaccine worked pretty well against the original strain, as you would guess. But as soon as a variant emerged that wasn't quite the same, it takes root. And that's how vaccines are. They're going to find ways to express themselves. So let's come to your question about the future. The bivalent vaccine that you described is a step forward, because it will get the old strain that will sort of give some amnestic response from the immune system, especially those who have been vaccinated, but for that matter, even those who have been infected previously and never been vaccinated. That's good. But the specific BA.5 variant as part of the mRNA vaccine, I think, will get us back toward protection like we saw in May or June of 2021 before the Delta emerged. What are the downsides? Well, we won't have extensive safety data of that combo vaccine. And there's an assumption buried in this release that the vaccines, even with the newer component, will be relatively safe and at least more or less as safe as the original vaccines. I think that's a fair assumption, but it's still an assumption. Secondly, I think it's very likely that even with a BA.5 variant vaccine, that by the time we're giving that, some other variant will have already been emerging. We see this now. There's a variant, again, I think out of India. I forgot its name, but it's another Omicron-like variant that's starting already to take hold. And so by October, we may already see that one coming up. But still, to me, a broader immune repertoire that any person's immunity can have against these types of pathogens is beneficial. Think like the flu. We get a shot every year with different variants. We also don't test those vaccines for safety prior to their release. We shuttle in Ann Arbor B and different types of A variants, just because we know over time that those things have worked and have been safe for the most part. We've been surprised a couple of times, like with the swine flu vaccination back in the 70s, if you remember that. There were some side effects, a little bit more Guillain-Barré, that type of thing. But we don't have much choice, because the longer we wait to release vaccines, if we're going to buy into this variant and immune system repertoire approach, then we don't have any time to wait for long safety evaluations. So the public should be aware of that as they step forward to maybe get one of these vaccines. But I would be in line with my sleeve rolled up to get it.
Me too. Um, I've already talked about the infrastructure and supply. Anything else you would like to say in sum about COVID-19? And I'd like to get you back to talk about monkeypox in the next couple of months so that we can talk about that. But any kind of summary, because it seems like we seem to be on the right track. We've got a difficult disease. Oh, I'd like to talk just for a second about masks. That's what I'd like
Mhm.
to talk about. Um, what I guess the question I have is, one, should we still be wearing masks? And two, what kind of mask should we be wearing?
Okay, well, the first thing is, despite what you hear on social media, masks work. You know this because you don't want a surgeon operating on you not wearing a mask, because the respiratory route spreads germs and disease. When you have a respiratory virus, that's even more important. When you know that it's something that's transmitted by the air, and if you think about it, the real protection is coming mostly by having a mask on the person who perhaps unwittingly is infected, and as they breathe out into their environment, much like pigpen and peanuts, so this cloud around them,
Yep.
you put a mask over it, you reduce that cloud, and therefore you reduce transmission. Coming back to which masks work best, we're really talking about on this hand on the recipient. So if you have a loose fitting mask that allows a lot of air coming in around the sides, not going to do a whole lot for you, maybe 10 to 20% protection. You have a fairly tight fitting N95 mask or something close to it, you're going to get protection up to 60 to 70%. And if everyone around you is wearing a mask, that collective protection can be up into the 90% range. So to answer your question directly, I think we can be smart and use masks when we see increases in cases around us. I think we should voluntarily do that. I do that. I hardly ever go into a really crowded environment not wearing a mask. The exception would be a restaurant. And I understand that I can't eat with a mask on. So I've made a choice when I walk into the door of a restaurant that I know I'm going to have some exposure. But if I'm at a crowded sporting event, or if I'm in another crowded area with a lot of people and the numbers are kind of high, and I would define that as more than 5 cases per 100,000 or something like that, then I'm going to wear a mask. What's the harm of it? It doesn't hurt me. And it might help people around me, and I wish other people would as well. We should only get back to mask mandate if we see another huge surge like we saw, say, in January 2022 with Omicron, or in January of 2021 with Delta. We saved lives with masks in those settings.
Let me close by asking you about a book you wrote, a memoir, and you can see it in the back there, Positive, One Doctor's Encounter with Death, Life, and the U.S. Healthcare System. Tell us just a little bit about this book, and then I'll let you go.
Yeah. Throughout my entire medical career, even pre-med, I was angry about how we delivered healthcare in the United States, mostly for its disparities and inequality, that it mattered not only if you had insurance or not, that was huge, but even the type of insurance you had. There might be caps, there might be things that restricted access to care. And at the same time, we kept acting like healthcare was a free market system, but it's anything but, because you always have a buyer who has to buy. And free markets are based on the concept the buyer can walk away.
Right.
if they want to, from buying a car or cell phone. We can't walk away from buying healthcare. So that whole thing was irritating. I kept waiting throughout my lifetime, to quote Bruce Springsteen, for a savior to rise from these streets and do some sort of healthcare reform. But it would have happened with Johnson, but for the Vietnam War. I think Nixon might have done something, but for Watergate. It probably wouldn't have happened with Carter, Reagan. But with Clinton, they tried and it got destroyed by the Harry and Louise ad. So finally, Obama came along and adopted this concept of Obamacare, which was really a Heritage Foundation thing that was implemented by Romney. And he wrongly thought that the Republican members of Congress would embrace it because it came from a conservative think tank. He didn't. So I was angry that we didn't have the national debate on what should our healthcare system look like. So I said, I'm going to write a book. And then I realized that was more of a rant. Then a friend of mine said, why don't you couch it in a story? So I made it a combination memoir. Sorry about that. But how AIDS went from a death sentence to a chronic manageable condition. And in that story, I wove in issues about the healthcare system and what I think we can do to fix it.
And where can we get this book?
You can get it on Amazon. You can get it pretty much through any
I was about
bookseller.
to say bookstore, but I don't think we have bookstores anymore. Do we have those in the United States?
We have some for people who really like to browse books and pick them up and feel them in their hands, but that's becoming anachronistic at this point.
Michael Saag, I really, really appreciate you. This has been great, and I want to wish you well, and hopefully we'll have you back on again.
Great. It was great being with you again.
Thank you so much.